Welcome everyone. Thank you for joining the Essentials in Pediatric Health Assessment webinar hosted by Connected Care at Sick Kids. This is an overview of basic principles in pediatric health assessment. Please take a few moments to review this disclaimer, and you may pause it at any moment if you need more time to review the content on the slide. The following objectives will be covered in this session. Those include discussing key considerations in the caring for the pediatric population, reviewing developmental milestones as they relate to performing a pediatric health assessment, discussing rapid assessments for the pediatric population, recognizing the clinical signs of deterioration, reviewing components of the pediatric health assessment, and reviewing pediatric pain assessment. It is important to consider the differences between pediatric clients or patients and adults. This will help to guide the strategies you use during your assessment and while providing care for pediatrics. Let's go through some of the differences to consider when assessing pediatric patients. The child is part of a family unit. Depending on the age of the pediatric client, you may be speaking to them as well as their family caregivers for updates on assessment, changes, goals, and their plan of care. It's important to promote independence of pediatric clients and include them in the discussion as appropriate. There are also different developmental stages for pediatric clients, and these may differ from their chronological age. You need to have knowledge of the developmental stages when performing assessments and how they may influence your findings. There are anatomical differences between pediatrics and adults that may impact your assessment. For example, children have larger heads, thinner skin, their airway is more narrow, they have shorter necks, and softer bones. And these can influence the way a child responds or compensates to medical changes. There can also be differences in how medications are administered, as well as how the child may respond to medications. The dose of medications are weight-based for pediatrics. There may be an increase in side effects to the medication due to organ immaturity, an immature blood-brain barrier, a lack of research on the drug efficacy, and a lack of exposure to medications. Different compensatory changes may also be noted for children. For example, children are more prone to dehydration and heat loss than adults because they have more body surface area per pound of weight, and they have thinner skin, and they breathe faster. Also, vital sign changes signaling decompensation can differ for pediatrics versus adults. For example, blood pressure changes can be a later sign of decompensation for pediatrics. We are going to take a moment to review the different developmental stages and how you can adapt your health assessment to accommodate them. Remember that each child may develop differently. It is important to understand the child's baseline and any conditions that may affect their development before starting your assessment. The term infant covers the first 12 months of age. During this developmental age, the infant may look to their caregiver for security and can respond to the caregiver's anxiety levels. It can be helpful to include the caregiver in the assessments to promote feelings of safety for the child. During this stage, starting with the least invasive assessments can prevent crying and moving, which may affect the results of the rest of your assessment. For example, when checking vital signs, blood pressure and temperature may invoke crying, so it may be helpful to save those till the end. The toddler stage encompasses years 1 to 3. During this stage, the toddler is starting to explore their surroundings and become interested in play. It can be helpful to provide explanation of what you are doing, as well as incorporating play into your assessment. Allowing the toddler to touch the equipment can also make them feel safer. The preschool age is from 3 to 5 years. This child may ask more questions and want to know what is happening during this stage. Using play and explanation can be helpful with preschoolers as well. The child can feel more comfortable when they are included in their assessment. School-age children are from 5 to 12 years of age. A key feature of this age group is that they're starting to seek autonomy. Providing time to explain the procedure or assessment and providing options for the child can be helpful. When providing options, it's important to avoid yes or no questions, because if the child answers no, you may be in a challenging spot if the assessment or procedure is required. A different way of providing options may be to ask them which assessment they would like to be done first and offer breaks. This can include them in the decision making while still being able to complete the needed tasks. Adolescents strongly value autonomy, and providing opportunities for decision making is important. Full discussion of procedures and assessments is required to allow for choice and understanding. It is also important to provide time and privacy to promote independence. This chart shows the average ranges for pediatric vital signs. You'll see that there is a difference in pediatrics versus adults, as the ranges can change based on age. It's very important to know what the child's baseline is in order to interpret changes. Just like adults, pediatric vital signs may change based on physiological and non-physiological causes. These are important to consider when interpreting vital signs, as it may explain abnormal results. Prior to assessing a child's vital signs, assess the surrounding environment to know how it may impact the child. For example, is this the first time you're meeting the child and the family has left the room? Is the child anxious or fearful of you? Was the child recently active or were they asleep? Is the child in obvious pain or are they crying? It's also helpful to consider physiological changes that may impact their vital signs. Do you suspect that the child has a fever or are they showing signs of respiratory distress? Has there been a recent injury? Have they taken any recent medications? These physiological and non-physiological causes may provide values that may not be a true reflection of the clinical status, or it may give you a better understanding of what their clinical status is and areas that you can focus further assessments on. Rapid assessments are designed to be completed in less than 60 seconds with no equipment to determine if the child looks good or if they look bad. Things to consider during a rapid assessment include: what is the child's general appearance? Is it their baseline movement, posture, or activity? How are they interacting with you as well as with their family? Does the family appear or verbalize their concern? Does the child appear frightened or concerned? Are there changes from the last time you interacted with the child? Take a moment to reflect on your past experience. Have you ever walked into a room or a client's home and had a gut feeling that something was wrong? What was the first thing that you did? The Pediatric Assessment Triangle, or PAT, is a tool to complete a rapid assessment. A key part of the PAT is knowing the child's baseline normal behaviors. It's a quick 60-second scan of the child's general appearance, work of breathing, and circulation. When assessing the child's appearance, a helpful mnemonic is TICLS, T-I-C-L-S. This recalls the areas to assess for their general appearance. This includes the tone, interactivity, consolability, look or gaze, and speech and cry. You're assessing the child's muscle tone and their mental status. Thinking about, is the child alert and active, or drowsy, lethargic, and limp? When assessing the child's work of breathing, you can assess the breathing pattern, rate, and any audible sounds you may hear, and a reminder to compare it to their baseline. Are you noticing anything about the pattern of breathing? Are they breathing deep or shallow? Are you noticing whether there's any increased work of breathing, such as nasal flaring or extended head positioning or any accessory muscle use? Are they breathing faster or slower than they normally do? Are you hearing any abnormal audible sounds, such as wheezing, gasping, or grunting? The general circulation can be assessed by observing the child's skin color and temperature. Is the child's skin tone their baseline, or do they appear pale and dusky? Are there signs of mottling or cyanosis? Does the child look warm and dry, or do they appear flushed and moist? Here are some examples of early and late assessment findings that would indicate a shift from the child's baseline. For example, when using the PAT and assessing the work of breathing, early signs may be tachypnea and retractions, whereas late signs might be tachypnea with increased effort, and later signs may be gasping, ineffective breathing, and no respiratory effort. When you're assessing circulation, an early sign might be tachycardia with pale, cool extremities, whereas late sign might be cyanosis or poor perfusion. A later sign might be arrhythmias or weak pulses or inadequate perfusion and gray skin tone. When using the PAT to assess the general appearance, early signs may be irritability or restlessness to lethargy, whereas late signs might be stupor with decreased brain perfusion, and later signs may be unresponsive, flaccid, or tonic posturing. Let's take a moment to use the pediatric assessment triangle in a scenario. You're caring for a 6-month-old infant who is admitted with RSV. You walk into their room and you're performing your rapid assessment. During this assessment, you find the respiratory rate is 62 breaths per minute, mild retractions, the infant is warm and well perfused, and they're crying and consolable by their family. What are the areas of the PAT that are affected? What would you do next? Take a moment to think about this situation, and we're going to discuss it in more detail in the later slides. In this scenario, there are abnormal findings associated with the work of breathing. The average respiratory rate for a 6-month-old is 22 to 52 breaths per minute. A respiratory rate of 62 with retractions are abnormal findings. Take a moment to reflect on the resource that you have access to. Are you able to call someone for help? Do you have access to provide oxygen if needed? If you're in the home, consider when you would take the child to the emergency department. 30 minutes later, you're reassessing the 6-month-old infant, and now you know the respiratory rate has increased to 60 breaths per minute. The retractions have worsened and are now accompanied with nasal flaring and grunting. The infant also appears pale with cool extremities, and they are crying and consolable. This is a quick change in the clinical status, and you need help urgently. You are now noticing changes in the work of breathing as well as the circulation. Take a moment to reflect on the resources you have access to and who would you call for help. A reminder that hypoxia is a late finding of decompensation and with little warning before it can turn to complete respiratory failure. Now that we've looked at ways to complete a rapid assessment of a pediatric, let's take a moment to look at ways that we can complete a thorough assessment of all systems. Let's start with the respiratory system. This is an important assessment in pediatrics due to the physiological immaturities of the respiratory system, their exposure to viruses in different settings, and the incidence of asthma and allergies in children. The 3 main methods for assessment are inspection, auscultation, and palpation. While completing an assessment of the child's respiratory system, remember to consider what the normal ranges are for that child. Inspection is recommended to be completed first. This allows you to gather information prior to getting too close to the child or touching them, as this may cause them stress and alter your findings. You can inspect the size and shape of the chest movement. Are you noticing the breaths are shallow or deep? Is there a symmetrical movement? What is the child's respiratory effort? Do you observe any nasal flaring, retractions, accessory muscle use? Are they in the tripod position, which is hunched over, trying to breathe? Are you able to see any oxygen saturation with an oximeter? After completing the inspection, you can then auscultate the chest with a stethoscope. You want to auscultate all lung fields and compare both sides, listening to the front and back and to the right side for the right middle lobe. Ensuring there is adequate entry to all lobes is important. You also want to auscultate for the quality and characteristics of the respiratory effort. You are evaluating the rate, rhythm, depth, quality, and any abnormal or absent breath sounds. For a pediatric context, babies breathe mostly through their nose for the first 6 months of age. It's important to keep blankets and toys away from their nose or their mouth, and if they're congested, it can be difficult for them to breathe. Babies and young children will use abdominal muscles to pull the diaphragm down for breathing, as well as their intercostal muscles are not fully developed. You may see belly breathing. During a respiratory assessment, you may hear abnormal sounds. We are going to go through 4 common abnormal sounds in pediatrics. Stridor is a high-pitched noise that occurs with obstruction in or just below the voice box. Stridor can happen when a child inhales or exhales or both. Wheezing is a high-pitched noise that occurs typically when breathing out on expiration, and it usually is due to a spasm, narrowing, or obstruction of the smaller airways in the lungs. Crackles are fine, short, high-pitched, intermittently crackling sounds. The cause of crackles can be from air passing through fluid, pus, or mucus. It's commonly heard in the bases of lungs during inspiration. Grunting is forced expiration caused by breathing against a partially closed glottis. This is a visual representation of the differences between an adult and a child airway. You can appreciate, due to these differences, how children are prone to obstruction, airway narrowing, upper respiratory issues, and difficulty with intubation. These differences include a cone-shaped airway in children, which means it's wider at the top and narrower at the bottom. Children tend to have larger tongues in relation to their mouth, and children have shorter and softer tracheas. All of these things can contribute to why children are predisposed to respiratory distress and may require admissions for viruses that may just be common colds for adults. Let's take a moment to review the signs of respiratory distress, including red flags as well as late signs of respiratory distress. Red flags of respiratory distress include tachypnea, changes in the mechanics of breathing, retractions, a tracheal tug, nasal flaring, head bobbing, grunting on exhalation, prolonged expiratory phase, diminished air entry, change in breath sounds, stridor, and wheezing. Late signs of respiratory distress include skin color changes, such as changes to dusky or cyanotic, inaudible air entry, or apnea or irregular respiration. Similar to the respiratory system, the cardiovascular system assessment includes inspection, auscultation, and palpation. We will go through each of these separately. During inspection, you are looking for the color and perfusion of the child. What is the color of their skin? Is it appropriate for their skin tone, or is it at their baseline? What is the child's perfusion? Are they pale or are they well perfused? Do you notice any signs of edema or swelling? This may be more noticeable around the eyes, the hands or the feet, the ankles, or the genitals. Listening to an infant or child's heart rate can be very challenging without practice, as the heart rate can be very fast. It can be very helpful to tap a finger or a foot to help you count the heart rate. It may also take a moment to discern the heart rate from the breath sounds, so make sure you know which you're listening to before you start counting. As part of the cardiac assessment, you want to listen to the heart for a full 60 seconds manually at the apex. You also want to ensure when you're taking the blood pressure that it's taken on the arm at level of the heart while resting. You want to ensure that you have the appropriate size cuff, meaning the cuff is 75 to 80% of the upper arm to ensure the most accurate blood pressure reading. A Doppler blood pressure machine may be more appropriate for infants, however, they're not always accessible in the community. So a manual or automatic blood pressure cuff can still be used if the child can stay still. It's important to know the most appropriate central and peripheral pulses based on the age of the infant or child. For infants, the brachial or femoral pulses are the most appropriate central pulses, while older children, the carotid pulse is more appropriate. Examples of peripheral pulses include the radial, pedial, or post-tibial pulses. When assessing pulses, you want to compare both sides. When assessing capillary refill, press against the skin until it turns white or blanches and count the time it takes to go back to its baseline. Before moving on, think of any conditions or treatments that you've seen that have influenced a change in the heart rate, temperature, or blood pressure of your patient or client. What actions were taken to resolve these changes? Things you may consider are fever or sepsis, the use of Ventolin, any dehydration in a child or infant, or any signs of increased intracranial pressure. Neurological assessments can be done at the first interaction, and depending on the child's underlying condition, more frequent assessments may be needed. It is important to know the patient or child's baseline to be able to compare for changes in their neurological status. Some general components of a neurological assessment include their level of consciousness, their mental status, their interaction, their movement, and their muscle tone. You can also look at any pupillary response. The Glasgow Coma Scale is often used to assess neurological status. The components of the scale include eyes opening, verbal response, and motor response. Other points to consider when assessing the neurological status of the child includes their age as well as their developmental stage. And are they responding appropriately based on these? Remember to consider for infants that may have open fontanelles, signs of increased intracranial pressure may not be apparent. Another component of the neurological assessment is any seizure activity. Seizures may indicate a change in neurological status. Remember, it's important to understand if seizure activity is known to the child or if this is a new behavior. If it's their norm, how do these seizures normally present? Are they currently their normal, or is something different? You will also want to know how they're treated and when they are treated. Let's move on to reviewing the GI and GU systems. Inspecting and auscultating these systems first is important to ensure you obtain accurate assessments. Inspect the general appearance of the child's abdomen. Does it appear larger than baseline? Do they appear distended? Is there any changes to the color of the skin around the abdomen? Remember that young children typically have a potbelly appearance. If measuring the abdominal girth is needed, you want to measure the girth across the navel. This may have to be done regularly for patients with certain abdominal issues. It may be helpful to mark the abdomen to ensure consistency for frequent measurements. You can also involve the family as needed. It can also be helpful to assess any output, whether urine or stool, and observe for changes from the baseline. This can include changing color, consistency, smell, or frequency. You'll want to listen or auscultate for bowel sounds in all quadrants of the abdomen and note any changes or abnormalities, such as diminished or absent bowel sounds. After inspection and auscultation, use light palpation to assess for any tenderness, firm areas, or any masses. Young children and infants who may not be able to express pain verbally will guard their abdomen and bring their knees to their chest in response to pain or discomfort. When assessing the GU system, it's important to consider the developmental stage and their need for privacy. Assess any anatomical abnormalities of the genitalia, any discharge present, changes in elimination, history of any UTIs, sexual activity, as well as menstruation. Hydration status is another important assessment for these systems, and this includes the urine output, any moist oral mucosa, what the skin turgor is like, as well as assessing the fontanelles in infants. It is important to understand the child's fluid balance. How you assess intake and output may vary depending on your environment. For example, in hospitals, total fluid intake, or TFI, and urine output calculations may not be measured the same way as in community or home environments. At home, you may not be weighing diapers or measuring the total volume of each void, but you can monitor output by assessing if there are less wet diapers than usual, or if you're finding that there is increased output. Or are there other signs of dehydration, such as dry mucous membranes, or the change in the color of urine, or anything that seems out of the ordinary? A normal urine output in pediatrics is 1 to 2 milliliters per kilogram per hour. One way of calculating the total fluid intake, or TFI, can be to calculate per hour. It can also be calculated for the total day, which we will look at next. To calculate the TFI for each hour, you can look at the 4-2-1 method. This looks at 4 milliliters per kilogram for the first 10 kilograms, that you would then add 2 milliliters per kilogram for the next kilograms from 11 to 20, and then 1 milligram per kilogram for every kilogram above 20, and this will give you an hourly rate. Now I understand that that sounds confusing, so let's look at an example. On the slide, you can see an example for a child who weighs 25 kilograms. If we were looking at the TFI for each hour, we would look at 4 milliliters for the first 10 kilograms. We would add that to 2 milliliters for the next 10 kilograms, and then we would add 1 milliliter for the remaining 5 kilograms. That leads to 40 milliliters plus 20 milliliters plus 5 milliliters gives us 65 milliliters per hour as our goal total fluid intake. Another method to calculate the total fluid intake, or TFI, is to look at the requirement for the entire day. You can use the infant or child's weight to calculate this TFI. For infants 3 to 10 kilograms, you will calculate it by multiplying 100 milliliters per every kilogram. For children 11 to 20 kilograms in weight, you will start with 1,000 milliliters and then add 50 milliliters for every kilogram over 10. For children over 20 kilograms, you will start with 1,500 milliliters plus 20 milliliters for every kilogram over 20 kilograms to a maximum of 2.4 liters or 2,400 milliliters per day. Working our way through the different systems of the body, we are now at the head, eyes, ears, nose, and throat, musculoskeletal, and integument or skin systems. When assessing the head, eyes, ears, nose, and throat, it is important to look for the size, shape, any lesions, lumps, or contusions. And as with other systems, visual inspection first is important. You want to compare the symmetry between the shape of the face, eyes, and ears, looking for changes in any hearing or any vision as well during this assessment. For the musculoskeletal system, it includes the back, joints, muscle, extremities, as well as gait assessment. Based on the developmental age, different milestones are expected to be reached, such as the ability to have head control, being able to sit independently, and as well as their motor strength. Discussing the child's norms with their family is important to understand if there are any areas of concern. For example, when assessing gait, it's important to know that toddlers have more of a broad-based gait, whereas preschoolers tend to start to bring their legs closer together. So when you're assessing gait, you want to know if there's any changes or if they're starting to favor an extremity over the other. This is important because if a child is unable to verbalize pain, this might be a sign that something else is going on or there's inflammation causing pain. A common gait problem is being pigeon-toed or toeing in, which results from torsion deformities. This is the long bones of the leg are turned inside or outside so the toes do not point straight ahead. The shape of the child's bones changes with age. For example, bow leg or knees that are more than 2 inches apart can be common in toddlers but may indicate problems if the child is older than 3 years old. Knock knees are when knees are closer together but the ankles are apart where they should be less than 3 inches apart, can be normal if the child is between 3 to 7 years old, but if it's excessive or asymmetrical or accompanied by short stature or evident that the child nears puberty, this may require further investigation. Additional assessments of the feet, joint, and muscles can evaluate a range of motion, quality of muscle development, the tone, and the strength. Some important considerations for the assessment of the integument or the skin of pediatrics include that the skin is thinner for pediatrics, and this can allow for injury or damage. There is a larger surface area in comparison to body mass for children. This means that there's a greater risk of excessive loss of heat and fluids. The skin can provide significant information of the child's nutrition, hydration status, and cardiovascular health. For skin color, it is important to consider cultural differences. Examples of changes in skin color are cyanosis due to poor oxygenation, pallor due to anemia, edema, and shock, petechia, which is small pinpoint hemorrhages suggestive of a blood disorder such as decreased platelets, and it can be distinguishable by attempting to blanch the skin, and it may not blanch away. Jaundice, which always is significant to note because it's caused by bile pigments. You want to be sure to ask about the yellow vegetable intake, such as carrots, as this can be a cause. But depending on the age of the child, it may indicate liver disorder as well. It can also be important to inspect and palpate for the texture, moisture, and turgor of the skin. Another important assessment is pain assessment in children. There are three main components to consider with pain assessments for children. These include their self-reported pain, your observation as well as what the family has observed regarding the child's behavior, and the physiological response to how the child reacts to pain. On the following slides, we'll discuss different tools that can be used for when assessing pain for a pediatric child. But before moving on, take a moment to think about a child in pain and what's the initial way that you would notice that they're in pain? Is it based on what the child says, how they behave, or how they react, or is it a combination? The first three pain assessment tools we'll discuss are ones that can be used when the child can self-report pain. The first being the word scale, which is commonly used for children 3 to 7 years of age, or when the child's unable to use the numeric scale. When using the word scale, you can describe pain as how much hurt, sore, pain does the child have? Is it none, a little, medium, or a lot of pain? There's also the numeric rating scale. This is commonly used for children over 7 years of age, or when they will understand a scale of 0 to 10. 0 being no pain, 10 being a lot or the worst pain they have ever had, and then they can describe how much pain they currently have right now. There's also the FACES pain scale. This is used for when children are, again, unable to use the numeric rating scale, and it requires the least degree of abstract thought because they can compare their pain to the FACES. Now, when you're using the FACES scale, you're not comparing the way that their face looks to these. You're having the child point out to what their pain is based on these photos. So they will pick the face that best represents them. However, it may represent mood and may be misrepresented based on cultures, so you may want to take that into consideration when using this scale. In addition to self-reporting pain assessment tools, there are also behavioral observation tools that can be used. Using these tools, you're observing behaviors of a child for a specified amount of time and looking at the behaviors to indicate that they're in pain, such as changes in facial expression, body movements, their cry, or their ability to be consoled by family. You also want to look at the context of the behavior and when it's experienced, such as any changes in health status, what their current state is, what's their developmental stage, was there anything that happened before the assessment that may change the behavior. Examples of these tools are the premature infant pain profile, or the neonatal infant pain scale, or the revised FLAC scale that looks at faces, legs, activity, cry, and consolability. When you're using these scales, you will assess the child's behavior and then find a number based on that. The higher the number, generally the more pain the child is in. Mental health assessments are another important component of pediatric health assessment. The mental status exam is a psychosocial assessment that describes the mental states and behavior of a person. The MSC can be used in any setting to evaluate concerns about a person's mental health. It includes both objective observations by the clinician as well as any subjective descriptions that was given by the patient or the client. One component of the MSC is the general appearance or behavior of the person. How does the patient or client appear to you? Is their posture and motor activity appropriate to the situation? Do they maintain eye contact? Do they appear relaxed, withdrawn, or irritable? What do you notice about their mood or affect? What are the patient or client's facial expressions? Can you ask them how they feel most days, or if they felt sad or discouraged lately, or do they feel energized or out of control? You can also take a moment to ask about self-harm or any suicidal or homicidal ideation. During the MSC, you're also assessing speech and language. This is assessing all aspects of the patient or client's speech, including the quality, rate, and volume, and whether it's appropriate to the situation. You're also looking at thought, content, and process. to help understand and evaluate what is the patient thinking. You can ask questions such as, do you hear voices when no one else is around? Or can you see things that no one else can see? Or do you have any unexplained sensations, such as changes in smells or sounds or changes in feelings? You'll want to evaluate whether the responses are organized or disorganized. The MSC also includes impulsivity, to estimate the degree of the patient or client's impulse control. You can ask the patient or client about doing things with or without planning and how they respond. The final component of the MSC is judgment and insight. To evaluate this, you can ask questions about their understanding of their illness or surgery if appropriate. You can also ask questions that require some thought or some decision making, such as, what would you do if you smelled smoke in your home? Putting the information together that you gather from the MSC, again, can help describe their mental state and the behaviors of the patient or the client. It also will highlight areas of concern for the patient's mental health. Before ending this session, here are a few key points to keep in mind when working with pediatric patients. Remember, children are not just little adults. There are physiological differences that are important to consider. The developmental age of the child can lead to a change in assessment strategies to allow for the most accurate results. You want to start with visual assessments and leave invasive or painful assessments till the end. Remember to be honest about what assessments are needed and what can happen in each assessment to prevent fear and mistrust. Understand the child's norms and include the family in the assessment. Interpretation of vital signs can change depending on the child's age. And remember to communicate any findings with the family as well as the medical team for further discussion and intervention. Thank you for attending this Pediatric Health Assessment webinar. If you have any additional questions, please do not hesitate to contact Connected Care.